Good afternoon. Welcome, everyone. Thank you for joining NCBA and Healthy Women. We are glad to present to you today this webinar on accessing current knowledge related to HIV, aging, and women's health. Our presenters today are Thais Diaz and Jessica Zajiski. Thais has a background in public health, nutrition, and chronic disease prevention and works as a program coordinator for Healthy Women. Her previous experience includes research and work at the University of Georgia, focusing on the undergraduate population's food choices, nutrition, and overall health and well-being. During graduate school, she was a part of a research team that studied nutrition apps and how they are evolving in the public health sector. She also worked closely with a pediatrician on her upcoming book related to nutrition, sleep, exercise, and family health. Thais focused on health literacy, public health advice, has volunteered with public health organizations that offer health education to Hispanic populations, and translated for migrant farm workers as well as physicians. She holds a Bachelor of Science degree in Media and Communication from Georgia Tech and a Master's of Public Health degree with a concentration in health promotion from the University of Georgia. Our next presenter, Jessica Zajiski, is a RN care coordinator at a large comprehensive HIV treatment center in upstate New York, where she works with underserved populations in both HIV and primary care settings. She graduated in 2004 with an AAS in nursing from Maria College and is experienced in both critical care and infectious disease. She volunteers through several local health care-based programs to promote health and wellness, and was honored with a Daisy Nursing Award for her work with HIV patients in 2019. She is the mom of two great boys, currently residing in Albany, New York, and is an avid Mets fan in her spare time. Thank you, Thais and Jessica. The floor is all yours. Thank you.
Thank you for that lovely introduction, and I will share the PowerPoint now. Okay, so today we are here to learn about the assessing current knowledge related to HIV, aging, and women's health. And I know we already did a quick introduction, but as a reminder, Jessica Zajiski works as a registered nurse care coordinator at Albany Medical Center, and then I am the program coordinator on the education team at Healthy Women. Just a little bit of background on Healthy Women and what we do and how we do it. We have three main focus areas of education and awareness, science and innovation, policy and advocacy. And how we do these are we have a 24/7 multi-channel media platform, healthywomen.org, where we offer an extensive library on diseases and conditions ranging from heart disease to breast cancer to HIV, and also some lifestyle and wellness topics. For science and innovation, we convene information exchanges that aim to advance and elevate conversations around unmet needs in women's health. Lastly, for policy and advocacy, we support and promote policy issues that are of importance to women's health with a focus on access, affordability, safety, and inclusion of women in science and research. And now I will pass it on to Jessica to give a background on HIV and a few more slides about diagnosis, transmission, and other important information.
Good afternoon. Thanks, Thais. As you heard, my name is Jessica Zajeski. I am an RN care coordinator for Albany Med Health System's Comprehensive HIV Treatment Center. We currently provide comprehensive medical and psychosocial care to over 1,200 patients living with HIV, as well as an additional 200 plus patients who protect themselves against HIV exposure using our PrEP program. So we're here today to discuss HIV, and let's start with a rundown of the basics. So HIV stands for the human immunodeficiency virus, which is a virus that attacks the body's immune system and when left untreated will cause AIDS. To contract HIV, you do have to be exposed directly to infected body fluids like semen, including pre-seminal fluid, vaginal or anal fluids, and then direct blood-to-blood contact with an infected person. HIV can also be spread from mother to child through breast milk or in utero. And there's a very low risk from unprotected oral sex, and HIV cannot be transmitted through urine, tears, or saliva. Now, if you're exposed to HIV, you may notice some symptoms of illness soon after exposure. About 30% of new diagnosis patients report feeling a flu-like illness after their exposure, and this is the acute phase of HIV, and it can last about 2 to 4 weeks. After that, it does develop into chronic HIV. Initially, patients can have no symptoms at all. Eventually, they can live for years feeling fine, but although they feel okay, their immune system is taking damage from the HIV, and they are getting sicker. Some patients do have some more noticeable symptoms as the disease progresses, swollen lymph nodes, fatigue, rashes, night sweats, body aches, and these can sometimes mistakenly be attributed to other illnesses or normal aging, and so then diagnosis and treatment can be delayed. And when treatment is delayed and the viral load is allowed to grow, your immune system will become severely immunocompromised. HIV replicates by invading your CD4 immune cells. These are a type of white blood cell known as your T cells or your helper cells because they help target and fight infection in the body. So HIV attacks these cells, and it actually uses the cell's own replicating abilities to reproduce more copies of the virus. And eventually that cell will burst, releasing viral material into the body and rendering the cell dead. So you have increased viral load, and then you have a decrease in those fighter cells that are working to prevent infection or fight off infection that your body may be exposed to. A healthy CD4 count is between 500 to 1,500, and once it drops below 200, a person is at risk for a host of opportunistic infections, and they can be classified as AIDS. At this stage of the disease, patients are severely immunocompromised, and they are susceptible to any infection. Something like a simple cold can drive them into the hospital. And patients can experience more severe illnesses as their disease progresses, things like recurring shingles, Kaposi sarcoma, which is a skin cancer that's seen almost exclusively in HIV patients, pneumocystis pneumonia, physical wasting, chronic yeast infections, or thrush of the mouth. And then eventually, when left untreated, it will cause death. So how do we diagnose this? Diagnosis of HIV is done by laboratory testing. Under the Affordable Care Act, HIV testing is covered by most insurances, so most HIV tests are available for free or reduced costs. In addition to that, there are many free testing programs available. So you can find testing at your primary care office, your local emergency room, substance abuse clinics, and if you are underinsured or uninsured or concerned about the cost or anonymity that goes along with HIV testing, you can access free and anonymous testing by contacting your local health department for a list of local resources. Okay, so there's currently no cure for HIV. Can we advance the slide, please? I'm sorry. So there's currently no cure for HIV, but we do have many treatment options available. And with adequate treatment, people living with HIV can have normal life expectancies and protect their non-positive partners from developing the disease. I'm not going to get too much into treatment options right now, because we will discuss it more in depth, but the medication that's used to treat HIV is called antiretroviral therapy, and it involves taking a combination of HIV medications. So the next bullet is about PrEP. This is pre-exposure prophylaxis, so protecting yourself against HIV beforehand, before you have that exposure. I think I'm off. I'm so sorry. I think are the slides out of, can we go back? I think I advanced the slide. I apologize. I'm so sorry. Okay. Back one slide. Sorry, right here. Okay. So I want to talk about PrEP. And no, next. I'm so sorry. Is there the slide with U equals U? Or did I apologize. Somehow I'm off my speaker notes.
Oh, do you need the U equals U? Yes, here it is.
Let me just see here. So testing, we did that, correct? So right here, U equals U. So U equals U, undetectable equals untransmittable. And that means that people with HIV who achieve and maintain an undetectable viral load, the amount of HIV in the blood by taking AR2 daily as prescribed, cannot transmit the virus to others. So in 2016, a health equity program called the Prevention Access Campaign launched the U equals U campaign. And this was a project led by people living with HIV to increase awareness and reduce stigma. So as we discussed, the amount of virus in your body is known as a viral load. People living with HIV who maintain a viral load of less than 200 copies are classified as undetectable. When they are virally suppressed to this level, it is not possible to transmit the virus to their partner sexually. The CDC currently defines undetectable as less than 200 copies. However, advancements in both medication and lab testing have allowed us to narrow that parameter down much smaller. Many facilities use a much narrower parameter for that. Currently, in my facility, we use a cutoff of 40 copies or less. And I'm thrilled to say that most of our patients do manage to stay within that range. And some are even completely undetectable with no viral copies being picked up in their blood sample. I do need to stress that U equals U is only applicable to sexual transmission, breastfeeding or blood-to-blood contact, for example. Sharing meals with someone who's undetectable may still infect you with the virus. Studies demonstrate that antiretroviral treatment greatly reduces the risk of HIV transmission from individuals who breastfeed or who share while injecting drugs. However, more research is needed to establish that these individuals do not transmit HIV. So right now, U equals U is limited to sexual transmission only. Okay, so I think now I need the slide for diagnosis. Thank you. Okay, so HIV diagnosis. According to the Centers for CDC and Prevention, in 2018, over half the people in the United States who were diagnosed with HIV were age 50 and older. And in addition, people ages 50 and older accounted for 17% of the almost 40,000 new diagnoses in 2018. Older Americans are more likely than younger Americans to be diagnosed with HIV infection late in the course of their disease, which can lead to poorer prognosis, more damage to the immune system, and shorter survival length after diagnosis. So why? Why are we seeing this increase in the number of older people who are diagnosed later in their disease process? And studies show that there's multiple things that contribute to this. Risk factors specific to this age population include things like being less likely to use a condom because pregnancy is not a risk at this age. Menopausal women may experience more vaginal dryness, and that makes the vaginal tissues more likely to tear during intercourse and increase the risk of transmission. When it comes to testing, generally older people are considered less at risk, and HIV may not be something that providers think that testing is warranted for. As I discussed earlier, sometimes patients are symptomatic, and those Symptoms are attributed to aging or other comorbidities, and so testing to identify the problem of what's going on may not actually include HIV testing. And in addition to those things, there is still a large amount of stigma that is attached to HIV. So some providers may feel uncomfortable discussing it or offering it to patients for fear of patients becoming offended. And conversely, some patients might feel embarrassed to broach the topic with their provider. I can tell you that I'm in New York State. HIV testing is a compulsory part of our health law, public health law. It is supposed to be offered to any patient aged 13 to 64 at any health encounter. And sadly, I have to say that I'm rarely offered this by my providers. So it may be a topic that you have to be the one to initiate the conversation. It can be uncomfortable. But hopefully some of the things that you learned today will empower you to take the lead, because you are your greatest advocate. If you think you need to be tested and it's not offered, ask. If you feel that your symptoms are being minimized by your provider, please tell them that you think it's important to look deeper into that. Delayed diagnosis does lead to poor outcomes for patients and sustained damage to the immune system. So on the next slide, we talk about HIV medications. And so how do we treat HIV? There is no cure for HIV, but it can be controlled with antiretroviral therapy. ART involves taking a combination of HIV medicines. And how does it work? ART works by interfering with certain proteins that the virus needs to replicate itself and spread. So for example, some medicines block the action of a protein that the virus needs to reproduce. Other medications block a protein that HIV uses to actually embed itself into your DNA so that it can make more copies of itself. So because the different medications work in different ways, doctors will often prescribe pills that combine 2 or 3 types of ART for more effective treatment. And currently the FDA has over 20 combination ARV drugs approved, and today most people start on a 1 pill once a day treatment option. And when someone is started on ART, the amount of the virus will start to decrease in their body. Most patients achieve viral suppression within 1 to 2 months of taking ART. So again, this means that the virus level is low, and as we see the virus level lowering, we see the T cells, or those helper cells, start to come back up. And this means that the immune system is now recovering from HIV's attacks. So to be clear, ART does not eliminate the virus. It's not a cure. HIV is able to hide dormant in some of your immune cells. And if you stop taking your meds, your HIV will start to grow again, and your viral load will grow, and eventually your immune system will take damage. So it's very important to take your medication regularly, on time as prescribed, to avoid what's called medication resistance. So HIV is a very smart and cunning virus. It can change its genetic structure to block the effectiveness of ART. And this is called drug resistance, and it increases the risk substantially when meds are not taken every day as prescribed. The most commonly prescribed form of ART is in a pill form. And again, most people are able to achieve viral suppression with 1 pill once a day regimens. However, some patients can require more complex regimens requiring more pills because of viral mutation and drug resistance. So taking your ART regularly as prescribed can help reduce your chances of that. Drug resistance is dangerous because it causes HIV treatment to fail. And eventually, if you develop enough resistance, your provider can run out of treatment options for you. Additionally, you can develop or get drug resistance initially when you get your HIV. It can be passed from person to person, and that's called transmitted resistance. So when someone has transmitted resistance, they're starting their ART regimen already with some resistance to some of the medications, so it can make it more challenging to find a therapeutic regimen for them. Most providers should do a resistance test at the initiation of your ART to make sure that that the regimen they're choosing is the right regimen for you. Most patients do well, and they have minimal side effects from their ART. But for those who do have side effects, the symptoms can lessen as your body adjusts to the medication. Most commonly reported side effects are headache, nausea, vomiting, diarrhea, fatigue, muscle aches, dry mouth, rash, and dizziness. And so your doctor may prescribe other medications like anti-nausea medications or anti-diarrheal medications to help alleviate those symptoms as your body adjusts. Now, there is more recently a new option available for ART in an injectable form. So patients who qualify for this need to have an undetectable viral load for at least 3 months and be medically stable without any resistance to the included medications. But it is an injection that delivers 2 drugs given every 2 months in the clinic for patients. It allows patients to be free from the daily burden of pills, the daily reminder of their HIV, pharmacy hassles, and we do have a lot of patients who are very excited to make that change and switch over to an injectable med. But we also have patients who are not there yet. They're happy to stay on their pill regimen. So discuss the benefits of each option with your provider and see what is best for you. So then I want to talk a little bit about PrEP and PEP. PrEP is pre-exposure prophylaxis, so protecting yourself against HIV before you are even exposed. PrEP consists of an ART regimen that, when taken consistently, it can protect you from HIV if you're exposed. It is generally available as a 1 pill, once-a-day regimen, and then just like with HIV, we have a newer option now of an every other month injectable. And PrEP works by setting up fortified walls around those CD4 cells that we talked about earlier that HIV likes to get inside and replicate. So if you take your PrEP medication every day and you have those barriers built up and you're exposed to HIV, HIV would be unable to gain access to those CD4 cells. You would be protected. It is important to note that PrEP does not protect you from STIs or sexually transmitted infections. So you do need still to use condoms for complete protection. And in addition, you should be seen by your doctor every 3 months for regular testing for both STIs and then, of course, HIV. And again, as with HIV testing, most insurance plans and state Medicaid plans cover PrEP under the ACA. So that means you can't be charged for your PrEP medication or the clinic visits or the lab tests that you need to maintain your prescription. And for patients who may be uninsured or underinsured, many states have PrEP assistance programs that can help cover both the cost of your lab visits, office visits, lab drugs, as well as medication. And you can locate that information at the CDC website. Excuse me. So PEP is, again, ART, and that is for people who feel that they may have been exposed to HIV and they're not already protected by PEP or by PrEP. PEP should be used only in an emergency, and it does need to be started within 72 hours. So if you think that you've been exposed to HIV from unprotected sexual encounters or other body fluids, there is medication available. PrEP is effective in preventing HIV, but it's not 100% effective. And we find a higher effective rate when it's started sooner. It absolutely has to be started within 72 hours, but the sooner that you start, the better off your outcome is. So if you think that you've been exposed, every hour counts, and please do not delay seeking treatment. You can go right to urgent care or your emergency room to access PEP. It consists of a 2-pill regimen that's taken once or twice a day for 28 days. It is important that you take the full duration of the meds to get the full benefit. And you can find that just like with other ARTs, this can cause some stomach upset, and it is very common that doctors will prescribe you some sort of anti-nausea medication to help you more easily take your PEP. While you take PEP, it is important to use other protection methods, so condoms for unprotected sexual encounters, clean needles if you're injecting while you're on your PEP. And I do want to, again, one more time stress, it's most effective when started early, so please do not delay in seeking treatment if you have had a potential exposure. So as I said, there are pills and shots available. It's really dependent on the person's lifestyle, their adherence to medication. What will be chosen for them is the correct regimen, and it's a discussion to have with your provider. Now, when we talk about women and HIV, if we can go to the next slide, please. So In 2019, nearly 1 in 5, or 20% of new HIV diagnoses were in women. Women aged 25 to 34 have had the highest number of new HIV diagnoses. And so why are women so at risk? Studies show that HIV is transmitted more efficiently from men to women during heterosexual intercourse. Biologically, there is just more mucus area and tissue exposed to penile penetration, so more chance of HIV to spread. And in that population, African American women are disproportionately affected by HIV, even more so. In 2019, Black and African American people represented 13% of the U.S. population, but they made up nearly half of the new HIV diagnoses. So in that subset, Black women continue additionally to be impacted by HIV, and they actually accounted for 60% of the new HIV infections in the U.S. In U.S. women, despite making up less than 15% of the female population. And although the rate of new infections among Black women has decreased over time, the decline has recently plateaued in recent years, and the rates of STIs in Black women are increasing. A number of challenges contribute to the epidemic among Black people, including higher rates of poverty, lack of access to health care, higher rates of some sexually transmitted infections, and then a lack of awareness of HIV status or stigma. And this all underscores the need for strengthened and more focused and innovative efforts to address this disparity. Statistically, Black women who have an involvement in the criminal justice system, including those in community corrections, so people on probation or parole, still within the criminal justice system, but external to prisons or jails, they're at particularly high risk. And in many communities of color, discrimination and stigma are significant factors that can deter women and girls from even knowing they should get tested or seeking more information on prevention and treatment options, and also in disclosing their status. Compared to their white counterparts, Black women experience longer delays in diagnosis. They're less likely to be virally suppressed, and so they have poorer outcomes and higher morbidity rates. And some of that may be because most of the recent HIV prevention efforts in the United States have focused on men who have sex with other men and transgender women. These are the groups that have the highest new rates of HIV and STI diagnosis, despite the ongoing disease burden that cisgender women face. So it is time for renewed prioritization of awareness and Black women's HIV needs. And it speaks to the need for new and multi-focused interventions that are feasible to implement and cost-effective, and that really provide Black women with PrEP knowledge and accesses to services that are necessary to end the epidemic. Overall, Black women in the United States experience substantially better health improvements over the last century, but disparities certainly still exist. Black women continue to experience excessive mortality rates compared to other U.S. women, including shorter life expectancies and higher rates of infant and maternal mortality. And I don't think any discussion of health equity among Black women is complete unless we do consider the impacts of institutional and individual level forms of racism and discrimination against Black people. Research consistently has documented the continued impacts of systematic oppression, bias, and unequal treatment of Black women, and that contributes as well to higher mortality rates and worse outcomes. Now, Black women are also disproportionately burdened by chronic conditions, things like kidney disease, diabetes, cardiovascular disease, and obesity. These comorbidities can complicate HIV treatment and lead to worse outcomes. I do want to take just a minute to touch on COVID-19 and vaccinations. There remains a large and understandable distrust of the medical community by the African American and Black community. Experiments like Tuskegee, eugenics experiments targeted at minorities, and particularly for women, the history of the unspeakable experiments that were done to forward the progress of gynecology, the story of Henrietta Lacks. These are all things that for women in particular can really foment fear and distrust. Early in the pandemic, we did see this distrust applied to the vaccine. Skepticism was certainly not limited to the Black and African American community, but it was heightened, and we did see that in the early days, Black Americans had some of the lowest vaccination rates. That gap seems to have narrowed as the vaccine has proven effective in preventing more serious disease and relatively low risk itself. However, distrust of the vaccine continues, some believing it's dangerous and some just think it's not necessary. Most people don't know somebody personally who has had a serious injury or death from the COVID vaccine. But I'm going to bet that most of us know someone who was made pretty sick by COVID. Maybe not hospitalized, but they were pretty sick from it. And this is important to note because as we just discussed, Black Americans have a higher rate of heart disease, diabetes, obesity, and kidney disease. These are all things that are known to be exacerbated by COVID and that increase the risk of complications or death from COVID. So it's very important for Black and African Americans to protect themselves from risk of more serious disease. And if you still have lingering concerns or hesitancy about getting the vaccine, I recommend having a very frank conversation with your provider about what your concerns are and see if they can assuage some of that for you. Now, HIV also affects women differently. It can cause some health problems that are unique to women, things like gynecological issues, recurrent yeast infections or bacterial vaginosis, increased risk of cervical and vulvar cancer, increased risk of heart disease, and then everyone has the potential for HIV medication side effects and drug interactions. Women in particular can also pass the virus to their baby during childbirth and pregnancy or breastfeeding. The good news is that there are ways to lower the risk of passing HIV to your unborn baby to 1% or less. And that basically includes taking your antivirals as prescribed. HIV positive women do and continue to have healthy pregnancies and healthy, beautiful babies all the time as long as they remain virally suppressed. However, you may need to switch your ART to a pregnancy-friendly regimen. So talk to your provider if you are thinking of planning a pregnancy so that you can make those changes before you become pregnant. I do want to mention that because U equals U has not been fully studied in regards to breastfeeding, it is generally not recommended for HIV-positive women, even those who are virally suppressed. So the next slide talks about HIV and aging, and according to the CDC, 59% of the people living in the U.S. with HIV were 45 years or older in 2019. 24% were 45 to 54, and 34% were actually 55 and older. People with HIV are more likely to have chronic long-term conditions such as diabetes, high blood pressure, high cholesterol, and chronic heart, kidney, or liver disease. Co-infection with hepatitis is also very common with HIV patients. So when a person has both hepatitis and HIV, there is faster progression to scarring and damage of the liver, and so there is an increased risk of long-term liver disease and liver cancer. People living with HIV are also at higher risk for certain types of cancers, including lymphoma, which is a type of cancer of the immune system, and HPV-related cancers. Specifically for women, this increases the risk of cervical and vulvar cancer. And other age-related comorbidities that we see include osteoporosis, frailty, increased fracture risk, as well as HIV-related dementia. HIV-related dementia or HAND can cause mood changes, decreased attention and concentration, slowed thinking, changes in body movements. It is more common in advanced HIV, but it's estimated that at least 25% of people living with HIV have at least some mild neurocognitive impairment. So aging and drug-drug interactions, as more patients age and develop more conditions, they require more medications, and that increases your risk of a drug-to-drug interaction. Medications for things that are as common and treatable as heartburn can interfere with the absorption or the efficacy of HIV medications. And so when we add in those conditions, it makes it more challenging to manage a patient's medication regimen. In addition, adding multiple drugs can increase a patient's pill burden and lead to treatment fatigue and burnout, which leads to treatment failure. So patients might find that as their medication burden grows, that they might find tips like using a pill organizer to set out your pills once a week, or to set a reminder timer in your phone. May make it easier to stay on top of your medications. And again, the keys to successful management of HIV include early detection and treatment and adherence to your medication regimen. I think I'm actually out of time, so I hope that I was able to provide some useful information that increases your HIV awareness and empowers you to take control of your health. So thank you for tuning in today and listening.
And I wanted to just give a minute or two for the poll that just popped up. We were curious to know which of the following applies to you. And the options are: I am a caregiver for someone with HIV, I know someone with HIV, I don't know anyone with HIV, or none of the above. And if Angela, you could just let me know once those results have come in.
Yes.
Perfect. Okay. So I wanted to give a brief description of our HIV and aging education program, where we aim to raise awareness related to HIV and aging among women ages 35 to 64 to help narrow the gaps in undetected HIV, health disparities, and health inequities. We also aim to increase education and awareness efforts related to early screening, diagnosis, medication adherence, and timely intervention, since late diagnoses often occur in older individuals with HIV. We also wanted to increase awareness of the clinical characteristics and comorbidities associated with long-term HIV infection that are commonly observed in aging populations. And lastly, we wanted to expand the dialogue among women, healthcare professionals, and communities at large to clarify misconceptions, information about stigma, reproductive health, and other issues related to HIV. And lastly, we wanted to highlight our partnership with the National Caucus and Center on Black Aging, NCBA. So far, we've completed 2 phases of the Your Guide to HIV and Aging program. Phases 1 and 2 included deliverables on different topics in a variety of formats, including feature articles, graphic articles, infographics, videos, and Real Women, Real Stories. To the right, I have included a few titles of our deliverables, which include When Grandma Has HIV, It May Come as a Surprise, but Older Women. Oh, I just saw the poll results came in. I'll just do a quick overview of those. So for the first one, I'm a caregiver for someone with HIV. 11% chose this option. 33% said that they know someone with HIV. 28% said, I don't know anyone with HIV. And 33% said none of the above. I'll just jump back into these deliverables. And we also included some of the Spanish versions as well. So, esto podría sorprenderle, pero mujeres de mayor edad también pueden contraer el VIH. HIV in older women, the connection between HIV and mental health in the older adult, why isn't HIV care reaching those who need it most, a few real women, real stories where they shared their journey with HIV, and lastly, an Ask the Expert video about bias, stigma, and management of HIV as women age, which Jessica helped us with, along with one of her colleagues. And I wanted to, before we do the landing page, I have another poll, which is true or false. Older Americans are more likely than younger Americans to be diagnosed with HIV later in the course of their disease. True, false, I'm not sure. And I'll give you a minute or two to answer these as well. And if Angela, you could just confirm. Okay, I saw the poll. Okay, we have the results, which most people got this answer correct. The answer is true. Older Americans are more likely than younger Americans to be diagnosed with HIV later in the course of their disease, which we had 79% answer correctly, 7% said false, and 14% I am not sure. Okay, and here I have our landing page for the Your Guide to HIV and Aging education program. With these landing pages, we provide an introduction to the program. Some of the deliverables are also linked in this introduction, but below we have a resource list with Healthy Women resources, as well as other medically accurate, reliable resources such as the CDC and other HIV organizations, so that everything is all in one place and you can find resources when needed. And I will also provide the URL for this and the other resources at the end of the presentation. One of the deliverables that I mentioned earlier was this infographic, HIV in Older Women. Knowing your risk and getting an early diagnosis can save your life. So we highlighted an introduction of what is HIV, and then later a section about how as the population ages, more people above age 50 are living with HIV. So we'll see that in 2030, it's estimated 73% of people living with HIV are expected to be over 50. Later, we have sections about older women and risk for HIV, how delayed diagnosis means delayed treatment, a little pull-out bubble about did you know HIV medicine is called ART, which Jessica highlighted in her part of the presentation. And then lastly, kind of giving women those action items of what you can do. So women can get tested and treated, get regular checkups with your healthcare provider, consider taking PrEP, and start treatment as soon as possible if you find out you have HIV. Next, I have the infographic that we created in partnership with NCBA. And we wanted to highlight how aging with HIV requires whole person care. So HIV is a complex virus that affects more than just your physical health. We do highlight the physical health at the beginning, but we later go on to describe stigma, discrimination, how it can affect relationships, employment, mental health. And we also have a small section about our 2022 survey conducted by Healthy Women in NCBA and how only half of respondents knew that half of the people with diagnosed HIV in the US are 50 years or older, and a few other knowledge portions. And then lastly, we have a section about if you are living with HIV, you can care for yourself by taking your medication, finding a support system, exercising regularly, reducing stigma by talking openly about HIV, and highlighting again that U equals U, undetectable is equal to untransmittable. And lastly, some support group, toll-free hotlines, mental health providers, and how these can help you get important information and advice related to living with HIV. Moving on to the survey, from June to October 2022, we fielded an online national survey of about 400 people. Our survey goal was to explore knowledge related to HIV and aging, including diagnosis, treatment, testing, stigma, and barriers to care. Our qualifying criteria included aging, age requirements, gender requirements, and also a mix of people with HIV, caregivers, and people who know someone with HIV to give a few different perspectives. Our methodology was to send the online surveys through unique NCBA and Healthy Women links through email, newsletter, and social media avenues. We also promoted the survey on social media and tried to get as many people as we could to take the survey. And I've included some of the screenshots for the social media that we ran for the survey, and we put these across LinkedIn, Twitter, and Facebook, and we created 2 different posts and staggered the posts throughout the fall. Some of the key findings included overall, almost half of survey respondents felt that they were knowledgeable about HIV transmission, prevention, and treatment, with 44% saying that they strongly agree or agree with this statement. Overall, 1 in 4 survey respondents strongly agreed that they were comfortable discussing HIV/AIDS related topics with their friends, family, or healthcare provider. Other key findings include that even though women can get HIV at any age, 1/3 of respondents believed women do not have to worry about getting HIV after menopause. Also, about half correctly believed that half of people living with diagnosed HIV are 50 years or older in the United States. Survey respondents believed these statements below to be true, even though HIV medications have significantly improved. I've also included the true or false answers to the right of these statements. So the first one includes 44% believe that once someone has HIV, there is little that can be done to treat them. This statement was in fact false. 34% believed that HIV was a big deal 30 years ago and is not really an issue anymore. This statement was also false. 55% believed that with ART and early diagnosis, people can live with HIV for many years. This statement was true. 54% believed that older adults who are sexually active with new partners are at risk for HIV. This statement was also true. We also included a question about HIV transmission, which was, which of the following ways can HIV be passed from one person to another? I've bolded the correct answers to this question, but a few of the percentages include 71% HIV could be passed through sexual intercourse, 28% believed by hugging or kissing, 18% believed by sharing food or drinks, 22% through household objects, 20% by coughing or sneezing, and 65% by sharing needles, syringes, or other equipment for injecting drugs, 69% by receiving a blood transfusion or a blood product. We also included a question about HIV testing, and a majority of survey respondents reported that their healthcare provider had asked about HIV testing. Also, a majority of survey respondents had been tested for HIV, which you can see below that 73% answered yes for has your healthcare provider ever asked you if you wanted to be tested for HIV, and 78% responded yes for have you ever been tested for HIV. Challenges and future work. What we learned, most survey respondents felt that they were knowledgeable about HIV topics, but there continues to be misinformation related to prevention, diagnosis, transmission, treatment, and aging with HIV. Some of our future work and opportunities include a phase 3 of the HIV and aging education program. We recently launched this phase 3, and we're aiming to further education efforts with a focus on prevention, PrEP, and PEP. We also would like to encourage further partnerships with organizations, build an HIV support group finder to be modeled after our multiple sclerosis and breast cancer ones to offer people with HIV online resources, support groups on social media, in-person support groups, and maybe phone options as well. And our key takeaways are that based on the survey, education materials, and evaluations, women need to know about prevention methods, importance of HIV testing, treatment options, and U=U. I wanted to say a quick thank you to our survey collaborators, Rebecca Sager, Angie Bodie, and Keisha Lewis. And I have included the URLs for the Healthy Women resources that I highlighted during this presentation, which include the landing page and the 2 infographics, HIV in older women and HIV aging and whole person care. And lastly, these resources were created with support from Gilead and Merck and developed in partnership with NCBA. And I've also included my email in the top right-hand corner if you have any other questions. And Jessica and I would also be happy to answer any questions that aren't touched on in the Q&A for the last 10 minutes. Thank you so much.
Thank you, Thais, and thank you, Jessica. Keisha and I appreciate the opportunity to work with you and Healthy Women on such an important topic. At this time, as Thais mentioned, we'd like to invite our audience to ask their questions by putting them in the chat. And to kick us off, we have some questions in the chat. And Jessica, I know you answered them, and I want to go back, if it's okay, and just read them aloud to our audience. So I'm going to kick us off. Our first question asks, if Medicare and Medicaid covers HIV testing, and if so, can I get a test annually?
Jessica, you're on mute. There you go.
So I got it. So the answer to that is yes. Again, as I said, under the ACA, it's considered preventable health care. It's covered. It's definitely covered by Medicaid and Medicare. And you can be tested annually. You can be tested every time you think you're exposed. I don't know that there's a limit on the amount of HIV testing, that your insurance will pay for if you are someone who has high-risk behaviors.
Okay. And Jessica, I want to build on that just a little bit. 2 things you said for our audience. Sure. The ACA is the Affordable Care Act. And then you said
the Affordable Care.
Yes, thank you. You spoke to just a moment ago, high-risk behaviors. Can you define that a little bit for our audience?
So in terms of HIV, high-risk behaviors would be any time that you're regularly coming into contact with exposure to blood or body fluids. So people who share needles, who inject drugs, who have blood-to-blood contact that way, that's considered a high-risk behavior. People who have multiple partners or engage in unprotected sex regularly, again, those are high-risk behaviors. So if you're someone who regularly engages in those practices, you should be tested more frequently for HIV.
Okay, thank you very much. Our next question reads,
Welcome.
you said the safety of breastfeeding while living with HIV is unknown. Are there currently any studies exploring the safety of women living with HIV who breastfeed? If not, is there anything we as consumers can do to advocate for these types of studies? Great question.
So currently, there's not a lot of studies. And I think really what that comes down to is human trials for that would literally consist of possibly infecting babies with HIV. And I'm not sure that anybody wants to, sign up for that or sign their child up for that. We know that U equals U. We know that successfully virally suppressed patients have a less than 1% chance of transmitting that. But again, I think what it just comes down to is the risk factor, and that nobody really wants to take that risk and say, yeah, you know what, we think you're okay, and then in 6 months we have a positive baby. And so I think it really comes down to that. There are a number of very nutritionally sound, formula preparations on the market, and so babies are able to get everything they need without breastfeeding. And so at this time, hopefully that changes in the future, but at this time, breastfeeding is not recommended for HIV-positive mothers, even those who are virally suppressed.
Okay, thank you. Thank you. And our next question
welcome.
asks, can you give us some tips on how we can approach our provider about HIV testing? And then I'm going to add this handle on it, particularly for those providers who tell us you're fine, you look fine. How do we broach that conversation?
Like I said, it's uncomfortable. I hope that some of the information that you got today can kind of give you the courage to speak up and say that. But it is something that can be uncomfortable, and you just kind of have to come out of your shell and say, if they feel like they're minimizing, well, you seem fine. I think I might be at risk, and I would like to know my status. I think you might be fine. I agree, I may be fine, but I would still like to check and know my status for sure. If you find that your provider is not really listening to you, get a new provider. But in addition to that, there are several free testing options available. You can locate these at your local health department. Often there are community agencies that offer free anonymous testing. So if you're really that uncomfortable broaching that with your provider or having that as part of your permanent medical record, you can locate free community testing pretty much everywhere. And as I said, you can find what your local testing options are by contacting your Department of Health.
Okay, thank you. That's good to know. Perfect segue for the next question. If I'm diagnosed with HIV, do I have to disclose my health status to my employer, particularly if I have to take off for treatment?
So the short answer to that is no. HIV is a protected health status. Many states have laws on the books that prevent HIV discrimination. It's considered double secret health information, so it's extra protected. And you do not have to disclose to your employer or anyone else that you have HIV positive, or that you're HIV positive. However, there are some few exceptions if your HIV status directly impacts your ability to do your job. That's something that you would need to disclose to your employer. But if it's something that you are taking time off of work for and you're concerned about excess appointments or missing time off of work, I would suggest exploring FMLA options. That is a coverage for you that will protect you from getting the necessary time off for your medical appointments without any impact to your job status. And it does not require for your employer to be made aware of your status.
Okay, thank you. And looks like we have time for just 2 more questions. If we don't get to your questions, I'd like to ask Jessica and Thais if they would be willing to answer those questions and we get back to you. Is that okay, Jessica and Thais?
Yes, of course.
Okay, thank you. So the next question reads, can you speak to the safety of blood transfusions today?
So currently the blood supply in the U.S. is very safe. It's tested regularly. At one point in the beginning of the epidemic, that is where we started to see a lot of spread was in the blood supply. And so despite some of these scientists coming out and saying to the federal government, you know, it's tainted, the blood supply is tainted, and they didn't listen right away. So there is a distrust, a historical distrust, I think, for some people that the blood supply is tainted, or they may be exposed to it through that. But I will say that the increase in surveillance for HIV, the increase in testing through blood transfusion programs, the risk is very, very low. And so that's something that's deterring you from, you know, you're in a medical decision where you need to have, you know, a blood transfusion to save your life. I would say you're probably fine. I would also say that if it's something to save your life, HIV is treatable. And so whatever you're up against is probably not if you need a critical life-saving blood transfusion. But the blood supply today is safe in the United States.
Thank you, Jessica. And this is the great closing question. If I'm diagnosed with HIV, is there assistance available to me beyond mental health supports? And if so, what other supports are available?
So there are a lot of community-based supports. At least where I am in New York State, we are lucky to have a tremendous amount of resources. But there are federal programs as well. There is Ryan White funding that fund clinics such as mine, or ours, I should say, where we're able to offer complete person treatment. So we offer medical care, we offer drug and alcohol counseling, we offer individual counseling, case management, psychosocial support services, referrals to mental health care. And there really are tremendous amount of resources, both at a state and federal level, as well as community-based organizations. And so if you find yourself newly diagnosed with HIV, speak to your provider, ask them to help you identify local resources in your area. I don't want to talk too much about specifics because what may be specific to us here in New York may not be available to someone in Mississippi or in Idaho. So I would recommend that you reach out to your local resources, Department of Health, and your provider to locate services in your area.
Perfect. Thank you, Jessica. We are at 2 o'clock. I want to respect both yours and Thais' time and our audience. I want to thank you both again for joining us on such an important conversation. And I would like to extend the invitation for you to join us again in the near future to further this conversation of HIV and aging. To our audience, thank you for your terrific questions, and we give you back your day. Thank you.
Thank you so much.
Thank you. Have a great day.
Have a great day.
Thanks.